certainly the invitation. I'm very happy to talk to you today about a concept shift which I perceive in psychiatry, which will be of utmost importance for the treatment of patients, afflicted with the most severe form of psychiatric disorders. It's all about rewiring faulty circuits, the promise of deep brain stimulation for psychiatry. For a long time we have been concerned with the synapse and the synapse only. All medications developed were working on the monoaminergic synapse. If it did something there, it was a useful antidepressant. I think it's very important to think about networks of centers in the brain, which are all involved in processing of emotional stimuli, and I believe that these networks are dysfunctional and can be at least partly restored to normal function. Yesterday, this article appeared in the New York Times, really well timed. I was very happy to see that. Psychiatrist's identity crisis. An article which talks about the problem we have in psychiatry. What's in the pipeline? What are truly new concepts? What are concepts which bring us along, bring us farther, give us new ideas? And I found it very funny. It was expressed in a language of pills. The sentences we talk to our patients are pills. There's some truth to it, but absolutely. But it's in every crisis is a chance, because this crisis brings us to development of completely new ideas. In the same journal, in the New York Times, Eric Kandel, whom you all know, talked about the new science of the mind. And he said the key sentences were, we are beginning to discern the outlines of a complex neural circuit that becomes disordered in depressive illness. First, the neural circuits disturbed by psychiatric disorders are likely to be very complex. Sure, we knew that. The brain is complex. It's much more complex than, let's say, the heart or the gut. Second, we can identify specific measurable markers of a mental disorder, and those biomarkers can predict the outcome of two different treatments, psychotherapy and medication. That's another very important thought. It's not either or. I grew up, scientifically I mean, my medical education, in a time of war between biology and psychodynamics. Today we know on a biological level that's ridiculous. It's just two sides of a medal. And thirdly, psychotherapy is a biological treatment. Brain therapy, it produces lasting, detectable physical changes in our brain, much as learning does. Yes, psychotherapy does, but there are cases where you certainly need more than psychotherapy. Perhaps this is a little bit euphemistic, but I think we are, when we speak about treatment of treatment-resistant patients, we are a little bit in this area where we were on our Earth, on our universe, and now we begin to look through a wall and glimpse a totally different world. You all know this famous Renaissance depiction, and I think that this concept of networks is truly a germane, important one. Depression, very, very sad disorder, huge lifetime prevalence, diagnosed in 5%, treated in 3% of all humans worldwide. Tiny numbers. Why? Because it's such a stigmatized disorder. It increases both mortality and morbidity in comorbid medical disorders, such as cancer, such as cardiovascular disorders, and it is associated with the highest decrease of quality of life of all disorders. So, a really, really sad disorder. How did we treat it? You know it with psychopharmacology, and it all centered about this concept which has been dumbed down here to a level where even psychiatrists can understand neurobiology. If you have too little of these strange blocks going back and forth, there might be something wrong. All you have to do is to block the reuptake of these blocks, and you have a higher concentration, and depression is gone. This is an ad from a pharmaceutical manufacturer taken out some 10 years ago to explain the wider public what depression is. And this is a very, very dangerous concept. Why do I say that? Because if you have such a simple disease, you just need to take pills and the disease is gone, and if it's not gone, it's your fault. This gives an enormous pressure on our patients to get better quick and the easy way. How's the reality? You all know the outcomes of the study trial. Here conceptualized the percentage of patients which are still depressed after a treatment step, a stepwise algorithm where patients were treated first with one antidepressant. Those who didn't respond were switched into the next step. And John Rush wrote in the abstract, greater illness burden, for instance, depression chronicity, psychiatric or general mental comorbidity, like anxiety disorders, was characteristic of those who require more treatment steps. So we see there are some strange things happening. Depression chronicity, taking some pills and making a depression go away has nothing to do with chronicity. But we see more and more that depression is a disorder which changes the brain, not only functionally, in some way structurally, it really leaves scars on the brain. Now, let me quickly branch out to another totally different area of marketing, to shaving. It's only interesting for a man in this room, but women are invited to follow. The MAO inhibitors, trying tetracyclics, they were really giving a good shave, but they were dangerous. You could nick yourself with them. And then SSRIs were developed, much safer. I think the shave is exactly the same. But then SNRIs were developed, affecting two neurotransmitter pathways. And the jury is still out whether this gives you a closer shave. But you know what industry did in terms of in shaving. It came up with triple reuptake inhibitors. There are two substances in development currently which affect the dopamine system too. And we could guess, is the third monoamine really making that much of a difference? In shaving, we are at 5 blades now. Your fantasy can go on and on if you translate this into psychopharmacology. And my own take of the future for really treatment-resistant cases might be this, and I tell you a little bit more about that. In the beginning, I told you about my enthusiasm about neurocircuitry. There's clearly no depression center in the brain, but there are different structures which are all involved in processing of emotional stimuli. And it has clearly been demonstrated that in many cases of depression, these structures are dysfunctional. This thought has brought Tom Insel to write this lovely article in 2011 in Scientific American. Tom Insel, the current director of the National Institute of Mental Health, on faulty circuits. Neuroscience is revealing the malfunctioning connections underlying psychological disorders. And I'm pretty clear that some of you, including myself, are really afraid if you see a soldering iron here with vapors going up and just soldering around in the brain. But I will show you that you can do this in a reversible, very focused and safe way. Bertrand Nestler wrote this lovely article, New Approaches to Antidepressant Drug Discovery Beyond Monoamines, and tried to come up with a neural circuitry of mood. And first of all, you see there are different centers in the brain which have all been implicated in affective processing. And you see that the chemical interaction between these centers goes way beyond monoamines. GABA is involved, epidurgic, glutamatergic pathways. So there you have room for many more blades on your shaver. But they don't only communicate chemically, but also electrically. They maintain that dysfunctions of the frontal cortex and hippocampus might be responsible for the cognitive aspects of depression. The dysfunction of the hypothalamus is responsible for the neurovegetative symptoms of depression. And lastly, and as you will see, most importantly, at least for our research, nucleus accumbens and amygdala mediate aversive and rewarding responses to emotional stimuli. They might be responsible for anhedonia, anxiety, and reduced motivation. And indeed, I think anhedonia is the key feature of depression, and anhedonia offers you a way of treating depression with neuromodulation. What is neuromodulation? Neuromodulation refers to a reversible, very, very targeted interaction with brain function in order to normalize disordered brain function. Different approaches have been tested or are being tested right now for depression. First of all, you probably all know about repetitive transcranial magnetic stimulation or magnetic seizure therapy, which allows interaction with the frontal aspects of this disordered network. There's vagus nerve stimulation, a very interesting method where you have an implantable stimulator which is connected to the left vagus nerve. 80% of the fibers of the left vagus nerve are afferent fibers. This is the nucleus tractus solitarius, which has projections into the limbic system, a very clearly antidepressant modality too. And then lastly, and I think most importantly, deep brain stimulation, a method which allows very, very fine-tuned changes in function of the brain, changes a patient is not aware of, patients don't feel these changes. Here is a cartoon of how it is done. This is obviously the skull of the patient. Electrodes are traced below the skin to a neurostimulator. Very simple device, this technology from the 80s. It's like a heart pacemaker. And these electrodes are connected to these contact points deep in the brain where they can neuromodulate or change the function of brain tissue with very, very small electrical currents. What has been tested so far in depression, the subcallosal cingulate was the first target looked at so far. Then the anterior limb of the capsula interna, a really long, deep target, and the nucleus accumbens by our group. Here is a 3D representation of what you see there. This here would, this here is the anterior limb of the capsula interna target. This is the subcallosal cingulate target, and this is the nucleus accumbens. I'd like already now to point your interest to this green structure. It's the medial forebrain bundle, a structure which we think is key for mediating hedonic stimuli in the brain. Here I coded you the region. This is one of the first studies published by Andres Lozano and Helen Mayberg in 2008. This is the mean depression score of the patients. Within the first months, very, very marked decrease of depression. The manufacturer of the device they used they did a pivotal study, a large placebo-controlled study. The study, this is from the website, and you look very closely at this website. This study has been closed and is no longer enrolling participants. Sorry, not because they reached their goal, just because a preliminary analysis showed that placebo didn't separate from a real stimulation, so the study had to be stopped. What about the next target, the ventral capsule, ventral striatum target? Again, I told you it's a very long target. It was chosen in order to emulate historic ablative neurosurgical interventions. Here you have the same effect. I point to these tiny patient numbers that's common to all VBS studies. Very, very marked effect in the first month. Another one manufactured who was this target did a pivotal study too, and these are the results, and these results are really more than sobering. They have been published recently, 2 years after the study was finished. No, the study was not finished, it was halted too, after 30 patients. Here you see active patients and control patients, and you see that in the blinded phase there's absolutely no difference in their change scores. This is the Madras % change. There were some people who got worse in both groups. Very, very difficult to make any positive effect out of this. If you look at the sum scores, it's strange, but after the first 16 weeks, here in red, the sham group performed even better than the stimulated group. So 2 major pivotal studies failed. What does this mean? Does this mean that DBS doesn't work? No, not at all. There are many, many criticisms we could comment on about these studies. There were problems with these studies, with the selection of patients, with the speed of intake, with the different centers, center effects, comorbid disorders like axis 2 personality disorders. There are many, many problems. But these studies are responsible for the fact that there is sort of a sobering effect in the field where people say, oh, it probably doesn't work. I'm convinced that it works. There's lots of preliminary data, and I'm certainly convinced because our approach works. And let me comment a little bit about this. Nucleus accumbens and amygdala mediate aversive and rewarding responses to emotional stimuli. These are the key structures responsible for anhedonia. And now you might differ when I say anhedonia is such an important symptom. You might say anhedonia is seen in other disorders too, in OCD and schizophrenia. What do you mean by this? But a long, long time ago, when I trained in psychiatry at the Johns Hopkins Hospital, I was chosen with a depressed patient to appear in grand rounds to be interviewed by the chair of the department. And he said, Thomas, what are the symptoms of depression? And I started beautifully to count the 9 symptoms. And he said, no, not at all. You're completely wrong. There's only one single question you have to ask your patients to make your 10 seconds diagnosis. What do you look forward to next week, next month, next year? I was a little bit angry and said, come on, it can't be that simple. But from then on, I asked all my patients this question, and I found it extremely selective for depression. Here, Paul McHugh interviewing Cal Ripken. Cal Ripken is a famous baseball talent in the US. He is from the Baltimore Orioles. He's a really fun person, but this was an important teaching point he gave me. How are hedonic stimuli being promoted, processed in the brain? Simple cartoon, ventral tegmental area, uses the MFB, the medial forebrain bundle, to project dopaminergically. these impulses to the nucleus accumbens. The nucleus accumbens is like a relay structure which, when there is a really good stimulus, activates the prefrontal cortex. What are stimuli which are hypnotic for us? And by us, I mean everybody, every vertebrate, every animal. The reward system is absolutely key for our survival. It teaches us what's good for us: good food, sex, love, a good book, whatever, a good conference. And there are some great neuroscience examples. What stimulates the striatum, which comprises the nucleus accumbens? Money. Sure, we knew that. Very important for us. Money activates. The anticipation of a monetary reward. If I tell you next year you're getting 2,000 euros, this is what happens to your brain. In abstinent cocaine users who didn't use it for 2 years, when you show them in a picture a white substance, a white powder, that's what happens in their brain, because they remember how good cocaine was. Beautiful faces of the opposite sex activate the reward system, pleasant taste. If you like sushi, then this happens to your brain when you see this picture. Music, romantic love, and then probably the most Germanic studies I've ever seen in science. Sports cars contrasted with pictures of Fiat Cinquecento or smart cars would have this reaction. I think that's a male-only effect, but it is a clear effect. Sports cars really stimulate the reward system. And it's exactly this system which is dysfunctional in humans suffering from depression. One example, this beautiful study from Diego Pizzagalli, where we looked at the activation of the nucleus accumbens in response to a very simple computer game, a game where patients took risks, and in correlation of this risk, they could either win or lose small amounts of money. This was contrasted to healthy controls, and here you see the results of major depression patients. Look what happens with punishment. In punishment, you have a small decrease of blood flow of the ball signal in healthy controls, and an insignificant increase in the patients. They could not care less whether they lose money or win money. Here, this is the winning situation, so the feedback, you won, you get money, and the healthy controls are happy. This is expressed in the increased ball signal in the nucleus accumbens. Nothing at all happens in the depressed patients. They could not care less. There are important things in their life than hedonic stimuli. I showed you the human reward system, and based on the hypothesis that the nucleus accumbens is not responsive in these patients, we did DBS, Deep Brain Stimulation, exactly to this region. These were the results. Bettina Bevernick from my group is the first author. Responders, here in red, response means decrease of baseline depressivity by at least 50%. This is the group mean, and these are the non-responders. And funnily enough, even non-responders responded. None of our patients wanted to have the device turned off. These are the recently published 2-year results. You see the responders stay responders as long as stimulation continues. The non-responders stay on this level, which is much better than at the beginning, but they don't reach the response level. What are the outcomes? Very, very small numbers of patients, as you can see, but between 50 and 60% response. And when you say, that's a little bit meager, 50%, for this you drill holes in the skull, put electrodes in, put a stimulator in, you should have better response. And I have to tell you, these are patients who had up to 60 different treatments with ECT, with drugs, with psychotherapy, and did not respond to anything. Nobody would have expected these patients to respond. And in this case, 50% is really meaningful. 3 different targets, similar depression severity, similar effect size, and in all cases there were relatively high stimulation intensities. What does this mean? The more current you use, the more brain volume is being involved, is being stimulated. So if you say, I really specifically want to stimulate there, and you need high stimulation intensities, then there's something wrong with your target. How does this check out? We did a DTI study, diffusion tensor imaging study, and by we I mean Volker Koenen, my neurosurgical partner, and I did this diffusion tensor imaging study and looked where the medial forebrain bundle, here the left part, here the right part, is in terms of the targets which we just discussed. And we were able to demonstrate that this medial forebrain bundle is in close proximity to these targets. And we came up with the idea it's probably not about these targets. It might be about the medial forebrain bundle. What is the medial forebrain bundle? I told you that all vertebrates have it. Here you see a morphing between the human form, that's human, to the rat medial forebrain bundle. Rats are closer related to us than we might think, to some of us even more, probably. And this bifurcation in the human medial forebrain bundle, but you see it's a thick, very, very important structure. And we came up with the hypothesis that we would get a higher antidepressant efficacy at lower stimulation intensities when we would stimulate in the medial forebrain bundle closer to the ventral tegmental area. Did a little study called 4C, forebrain stimulation in depression, partly sponsored by a manufacturer, open study in 8 patients only, extremely treatment resistant, up to 43 failed treatments. And we did a DTI-guided implantation, meaning that in all patients we looked at their individual medial forebrain bundle and put the electrode exactly in the right place. Don't worry, I'm not selling you, don't want to sell you this ancient lamp, which probably in the 70s was seen a lot, because it's not a lamp, it's the medial forebrain bundle. And the targets I just talked about might be far out in the periphery in a fanning out fiber structure. And our idea was when you get closer to the ventral area, the origin of the medial forebrain bundle, then you might get much better effects at lower stimulation intensities. Here again, this 3D reconstruction. Again, the green fibers here, this is the medial forebrain bundle. It's not a cartoon, these are actual fibers taken from 46 patients together. And this is the stimulation target, which is far, far deeper in the brain. So we moved our deep brain stimulation target from the nucleus accumbens to the ventral tegmental area. Here you see a patient planning picture where we trap the DTI in one patient and put the electrode exactly at this spot. Now the most important and interesting finding we had was that the immediate effects in all patients were exactly the same. And when you have such a similarity, you know that you are in a phylogenetically old system. What do I mean exactly the same? Patients, and I tried to show you this in this example, this is without stimulation, that's with stimulation. Without stimulation, they were dozing on the operating table, but when they were switched on, they began to look around. In the animal world, you would call this appetitive motivation. They would say, oh, you're here, I didn't recognize you in this surgical garb. Oh, so many people in this operating room, that's impressive. They started in adequate verbal interaction. I wouldn't say that they had immediate antidepressant effects, but there was a striking difference in behavior in all patients without exception. They all liked the new situation, but not in terms of drug liking. Some were astonished about this sudden change, which they noticed themselves. The heart rate would go up in any of these patients exactly 10 beats per minute. What are the acute results? This is the response line. Again, the response, 50% reduction of baseline depression severity, measured on the MADRS. This is patient 1, 2, 3, 4, 5, 6, 7, and 8. And you see, very, very strange. This here is not weeks or months, that's days. Within 2 or 3 days, patients crossed the response line. There was one patient who did not respond. We believe that we know the reason for that, but all other patients showed a very, very similar reaction. How about long-term results? These are the long-term results, which we are just publishing now. The 8 patients, you see, this is the non-responder. We have one patient who is sort of a partial responder, but the other patients are full responders. They move back and forth. That's the fact of human life. If you switch on the switch, it's not just that depression is gone. The thing which changes that patients are able to process rewarding stimuli normally immediately, and this has an antidepressant effect. So if we take DBS one step deeper, we have large response rates, much higher remission rates in a very, very short time. The currently used is 30% of what has been used in other studies. Remember what I tried to tell you before, if you need large stimulation intensities, you're probably not in the right place. And August 14, this was one of the study endpoints. The patients were well for 12 to 29 months. This hasn't changed now. They're still 1 year later. All which are stimulated are well. And there were no major stimulation-related side effects, which is astonishing. You go really deep, deep in the brain, in a structure close to the brain stem. There were no major side effects. We went on. We designed a controlled double-blind study where we randomly allocated patients to immediate versus delayed switch on, 16 patients. This here shown it graphically. We know these patients for a long, long time in order to assess the diagnosis. Up to 2 years ago then, and the group A was switched on immediately after the implantation, while group B received sham stimulation in this time. When we analyze it, you see this result. In deep blue is no change in depression, showing you the last 3 months. Nothing changed at all in these patients. They were deeply, deeply depressed. And light blue is between 25 and 50, light yellow is between 50 and 75, and yellow is more than 75% improvement. And you see amazingly big change on the right side. Some of the patients which received sham stimulation had a response. Look here, number 14, immediate response, but not so in the second month. It goes back. So there is a placebo effect, or we call it setting effect, from just tickling the medial forebrain bundle, but if you go switch it on, the effect goes away. Just a last remark, deep brain stimulation is not only a putative treatment for very, very treatment-resistant patients. It might offer a way of understanding the brain better, and by doing this, developing new antidepressants. Probably most of you know Khalil Gibran, the Lebanese American philosopher who wrote this wonderful book, The Prophet. This is from the Prophet. I say unto you, they are inseparable, joy and sadness. Together they come, and when one sits alone with you at your board, remember that the other one is asleep upon your bed. Lovely idea, very, very interesting. We believe, oh, we are joyful people, there's absence of sadness. No, it isn't. We have the capacity for sadness is in our brain, it's just not engaged. And indeed, we believe to have found a neuroanatomical structure for this very simple system. I talked to you about the medial forebrain bundle. The medial forebrain bundle, when you stimulate it, it really it gives you an immediate capacity for enjoyment of hedonic tones. So this might be the happiness system. But there is another system which is separated in the brainstem but overlaps in the frontal cortex. It's the anterior thalamic radiation, and we, in a couple of patients with epilepsy, stimulated exactly here. And then when you do this, you get immediate sadness in patients which are not sad, which are not depressed. That's a simple hint as of yet. But evolution came up with simple solutions, and probably this is exactly this system in the brain, which, according to which one is engaged more, leads to sadness or to euphoria. So, enough of stimulation. I'm completely convinced that this is a dawn and not a sunset. Deep brain stimulation will certainly be developed into treatments for patients suffering from the most treatment-resistant forms of psychiatric disorder, mainly depression and OCD. Patients which did not have to, to whom we couldn't offer a lot until now, deep brain stimulation might be a solution for them. But even more importantly, deep brain stimulation serves as a research platform leading to completely novel conceptualizations about the underlying neurobiology of psychiatric disorders. Why do I say that? Because deep brain stimulation offers very interesting new avenues in terms of electrophysiology or microdialysis to look what goes on deep in the brain, places in the brain which were locked for scientific intervention before. And probably the best thing of this new conceptualization is that it will lead to a destigmatization of psychiatric disorders. I've shown you that only 3% of all patients worldwide with depression are sufficiently treated. Why? Not because it's just a gimmick disorder, it's a deadly, horrible disorder. People are ashamed, and that's sad. And I dream of a day where depressed patients can say, oh, I had some network dysfunction in my brain, stimulation took care of it. When you laugh now, it's not different than a arrhythmia patient who said, I had heart arrhythmia, this was really bad, now I had some medication, now it's gone. I dream of this day, and I hope that I will live to see it. The absolute prerequisite, and I didn't talk about this too much, not at all actually, is that we have a comprehensive ethical framework for research and clinical application to safeguard this extremely hopeful development. You know that neurologists use deep brain stimulation widely. It's the method of choice for dopa-responsive tremor in Parkinson's disorder. But here we do something different. We need to very, very carefully think about who to stimulate for research, for clinical application, because this is a hopeful development and probably the most promising development in clinical psychiatry in the last 40 or 50 years. Thank you very much.